So may I ask the panelists to come up to the podium, please? Okay, while everyone is taking a seat, maybe we can get a little better idea of the flavor of our audience. Would those who are general surgeons in the audience please raise their hands? And those who are colorectal surgeons? Thank you. If you have done 0 laparoscopic colectomy, please raise your hand. So everyone here has done at least one. Okay, so that means everyone put your hand up because you've done at least one. Okay, hands up. You've all done at least one. Okay, if you have done, no, keep them up. Keep them up. If you have done 5 or less, put your hands down. The others can keep them up. Okay, if you've done fewer than 10, put your hands down. Fewer than 50, put your hands down. If you've done over 100, keep your hands up. Why are you here? Okay, you can now put your hands down. Okay. Let's get an idea from the panel, who I'm sure have all done well over 100 cases, if not over 1,000. What percentage of your cases are laparoscopic? So Juan, if we start at your end, what percentage of your cases would you say are laparoscopic?
I try to approach every patient by laparoscopic surgery. No for big tumors, maybe for recurrence. But for other disease, I try to approach every patient. It's around 80%.
George?
I have a bit of a skewed, perhaps, practice, but most primary colon cancer I'll approach laparoscopically. With rectal cancer, it kind of depends on a lot of factors, whether there's associated metastatic disease and things like that, but a primary rectal cancer, I would say probably 75% will be approached that way, barring other factors.
Michael?
Well, I think yes. I mean, fundamentally all of them, unless there's some contraindication, which I'm sure everybody...
And what do you consider contraindications?
Well, I mean, someone like the abdomen we showed with all those crisscrosses on them, that would be a contraindication. A common sense aspect of it would be the main contraindication, really. Or I think that's it.
Okay, Pat.
And I think for some of those patients, peak port technique is a reasonable approach, and I think the hand assist can help in those cases where you make a small incision, perhaps lyse the adhesions, and then make an assessment as to whether you can do it laparoscopically.
Steve?
I think the contraindications for me, basically I try and do everything I can laparoscopically. However, reoperative pouches are not going to be laparoscopic. Most recurrent rectal cancers probably aren't going to be laparoscopic. Primary rectal cancers depends which way they randomize in the COST-2 trial. And the other one that kind of kills me sometimes is what would be a really nice laparoscopic abdominoperineal resection, but if the plastic surgeons are planning a VRAM flap and they're going to do it laparoscopic and they make a big midline cut anyway to take the rectus, I don't like it, but we end up doing it by laparotomy just because they're going to do it anyway. But outside of that, everything.
And John, what percentage of your cases?
Probably between 90 and 95%, unless the incision's going to be, unless the pathology is going to need a large incision to remove it, or there's some other reason that it's prohibitive, as has been stated. Okay.
Pat, I'm going to address this question to you. You may have a sense for where these cases are being done. We saw earlier there's about 250,000 colectomies and 50,000 proctectomies per year in this country, so 300,000 cases. And you said 1,400 board-certified colorectal surgeons. I'm going to say 1,500 because it makes the math a bit easier. So that's 200 cases per year per colorectal surgeon. So what percentage of colorectal cases do you have a sense of being done by colorectal surgeons, and what percentage are being done by general surgeons in the community?
think it's hard to know the exact numbers, at least from David Edzioni's data. It looked like about 1/3 of proctectomies were being done by colorectal surgeons and a lower percentage of colon resections for cancer and a higher percentage of stoma-related procedures. David Edzioni's data was through 2002, and I think we're seeing creep up for a percent of procedures performed by colorectal surgeons. Having said that, Dave Schutz has looked at a lot of the recertification data for colorectal surgeons, and if that gets published or shared, I think there'll be discrete groups of some surgeons who have a primary anorectal endoscopy practice, other surgeons who have a primary abdominal surgery, pelvic surgery practice.
Thank you. And again, any member of the audience, please feel free to come up to any of the mics and ask questions. One of the things we've seen at this meeting over the last couple of days are presentations by authors using large databases, NESQIP, other large state and national databases like the National Inpatient Sample, showing roughly maybe 20-25% of cases being done laparoscopically, but also in these very large databases showing improved outcomes. So as representatives of both SAGES and ASCRS, I'm going to address this to Pat and Steve. What's stopping SAGES and ASCRS from coming out with maybe a position paper on perhaps that laparoscopic surgery should be the preferred approach, given the outcomes are better?
Well, it's an interesting point, and that may well be the next type of position paper that comes out. Again, it's with the caveat by appropriately trained surgeons, you know, as Michael's done in the UK or as we've done here through a lot of courses that various people have run in the US, you know, your partners from Leahy Clinic and others having a lot of courses put on. So with that caveat, I mean, that probably will be a natural evolution because it's been proven again and again and again, all of the studies we've heard this week and in other meetings, and I'm sure we'll hear next month at ASCRS.
And what do you think what's the difference? It seems we move pretty quickly to centers of excellence for bariatric surgery and not for colorectal surgery, whereas bariatric surgery is for benign disease and we're dealing with cancer. So what's the difference between the two?
Well, that's, no pun intended, a big difference. And the big difference is that the laparoscopic patients are operated on by a group of surgeons who, by and large, are laparoscopic surgeons who then migrate into a subspecialty of bariatric surgery, by and large. I mean, there's a couple of open surgeons who still do it, but by and large, that's the group. There's no overlap. The problem we've had with rectal cancer centers of excellence is that there are many groups with vested interests. There are surgical oncologists, there are general surgeons, there are laparoscopic surgeons, although those two groups have largely melded, and there's colorectal surgeons. So there's a lot of different groups who are participating there, as well as gastroenterologists, plus throw into the mix radiation oncologists, chemotherapists, medical oncologists, and you know, suddenly it becomes very, very difficult to define anything. It becomes very, very amorphous to try and define it. And, you know, there are a lot of different things that are being defined. With the bariatric surgeons, it's fairly, there are good metrics, you know, the percentage of weight lost, how well the diabetes is controlled, what's happened to the sleep apnea, what's happened to their blood pressure. I mean, you can define those things fairly well. With rectal cancer, there are a whole lot of other issues. You know, what's the response to chemoradiotherapy? How appropriately is the chemoradiotherapy being delivered? When are you using a local excisional or other local technique versus a more radical technique? What's the percentage of sphincter preservation? All of these things. What type of reconstruction are you doing? What's the function relative to bowel frequency, relative to fecal incontinence? You know, and all of that is besides the standard, you know, outcomes of laparoscopy. And then there's the most important bits after that. What about recurrence rate and such? So it's harder to tackle. I mean, you know, there are a variety of groups working on it, and we're going to continue to work on it, but I think because of those reasons, it really keeps being the white elephant in the room that we talk about, but we keep ignoring it. We're not ignoring it, but it's taking a lot longer to get it done.
Speaker on your right.
Steve Stanton, I'm from Oakland, California. I was looking forward to the maximizing reimbursement talk for my laparoscopic surgery, but I enjoyed the rest of the talks very much. I was at a packed robotic lecture this morning about colon surgery, and I'd like to know how the panel views robotic colorectal surgery, whether that's a part of their practice.
Well, that's not going to maximize your reimbursement. Okay, anyone on the panel want to take that one? George, you do a fair bit of robotic.
I think I like to consider the robot as another tool for minimally invasive surgery, and for those patients for whom I will perform minimally invasive rectal surgery, I'll always do that with a robot. I think for me it is a superior platform for that. But you know, of course, all of the patients who undergo rectal surgery for cancer are done on study, whether it be on the COST-2 trial or our own data registration study.
Anyone else with thoughts on this?
I mean, I think that the robot has certain advantages. Being able to sew around corners is probably an advantage if you're going to do that. Besides for that, the main advantage is clearly marketing. It's a great way to get patients in, and it's very patient-driven. Yes, there's good optics, but you can get good optics with high definition. You know, yes, you can dissect low in the pelvis, but you can do that pretty well also with good laparoscopic techniques. I've not yet seen any evidence that it's superior. You know, when we started doing laparoscopy, although we didn't know the long-term outcomes, we certainly knew the short-term outcomes, and very rapidly it was apparent that there were short-term outcomes. They kept being proven again and again in terms of length of stay and pain and cosmesis and wound infection and the like. We've not seen that. We've seen a lot of proof of equivalence. We've not seen any proof yet of superiority. Now, if that happens, the paradigm will change. But for the moment, it's a very, very expensive way to do the same operation. It adds at least $2,000 per procedure. And by way of disclosure, I should be touting this technique and doing it because I had some great stock options from Intuitive. But, you know, I think for me personally, it's wonderful. For my patients, I'm not as convinced.
I would say that there actually is, I think Dr. Wexner is correct. There's a paucity of data, but there certainly is some data. There's comparative data looking at the quality of the mesorectal excision as an example, and where it's been shown to be the rate of having a complete mesorectal envelope has been higher when performed robotically than laparoscopically. I think at the end of the day, you can still perform, there are still patients in which you can perform the right operation. At the end of the day, the right operation has to be performed. Whether that be done robotically or laparoscopically or open, it has to be the right operation. In my hands, I would say it is easier to perform the right operation robotically than it is to do it laparoscopically. It also has advantages during the vascular dissection, where you can very precisely dissect around the vascular pedicles at their origin on the aorta, as an example. You can do en-bloc resection for more extended disease or lateral lymph node dissection, all of which can be done laparoscopically, but I would say that it's certainly much more difficult to do. And finally, I would say that we know that there are unanswered questions about minimally invasive surgery for rectal cancer. That's why there is a COST-2 trial. That is why there's an ongoing COLOR-2 trial. And I think that some of the limitations that were identified in the rectal cancer subset of classic may very well be related to the fact that the access within the pelvis is difficult. Lateral cautery injury, as an example, because because there's not oblique access to the planes. In fact, you're coming in from the abdominal wall, as an example, and these are all things that can be overcome. How do we find data to show these differences? I think it will take time, and hopefully there'll be enough patients who are done on the COST-2 trial that have been done robotically that may help us.
I'm just going to jump in here. You know, this certainly is not, the goal of this session was certainly not to get into a laparoscopic versus robotic discussion. That said, I think that probably the biggest draw of the robot is to be involved so that as the robot evolves into the future, perhaps there will be something that's substantive in terms of improvement. There's clearly not been any real data showing any benefit one way or the other. The data, as stated, I mean, your results are going to be highly technique-driven, dependent upon the surgeon who's doing the operation. So the data that's been shown is, I certainly think you'd be hard-pressed to hold up in that regard. I think really this has been a very interesting session, and I think there have been a lot of great talks given, and I would actually ask the people who are running large groups, and really that would be Michael and Steve and Pat, if you could maybe discuss how it is, you know, Pat, I thought you gave a great talk in talking about the diffusion of innovation, and if you could talk about how you handled within a group of surgeons who have their own biases and expertise, how it is that stone is pushed forward in terms of adopting a new technique, and how do we handle things and when you have people within a group who are resistant to that type of thing, and what is acceptable in the year 2011 to offer to our patients?
I think we not only went through all the stages of adoption and diffusion of innovation, but we probably went through all the Elizabeth Kubler-Ross stages also. Those of you that know my group know that well. I think some of the people that were the laggards or the late majority also migrated toward the patients that were not as suitable for laparoscopy, so the multiple previous operations and things of that sort. And I think that we were very fortunate at the time that laparoscopy took off that we had Peter Marcello rejoin our group, who was just fabulous in terms of teaching and training a number of us that had had no experience with laparoscopy, but it was a journey.
Michael?
Well, we have a very strong laparoscopic bias in the unit, not just for colorectal, but for esophagus, stomach, and everything else. And the one surgeon who did not embrace it, which was entirely a matter for him, wasn't somebody one had specifically appointed, just has not got any patients. And he's had to go and find other things to do. He doesn't get any resectional work because we've got good evidence even within the group of the difference between the open.
Now, is that driven by the patients and referrals, or is that driven by control of where the patients are
It's driven by choice. It's choice of the referring.
It's choice, or the choice of the patients and the doctor sending the patients.
The referring doctors and the patients, because it's so obvious, the difference. And literally, the one surgeon who really does not have laparoscopic skills no longer does any resectional work.
One last question as we're coming to the end of the session here. Michael, I really enjoyed the data you presented on the enhanced recovery after surgery and getting patients out in 23 hours. One of the things I noticed was no bowel prep. If you're doing more than just a segmental resection, like a proctocolectomy and J-pouch, and you don't prep the patient, how do you manage to get all that out through a little incision?
Well, this is absolutely surprising to me too, but it is a fact. I mean, the only patients who get preparation are the rectal patients. They get a washout. But that apart, it's not the practice of the unit to do any preparation. Most of them do come out, particularly the 23-hour. One of the criteria I said was that the incision had to be less than 7 centimeters. Okay,
2 last comments, one from John, one from Steve.
Well, I would just ask to the panel, and it's open to Juan, perhaps you'd like to say something, or, you know, it's an interesting story of what's happened in the UK in terms of referral, and one would think that that would be obvious everywhere around the world. Why is it, there's a lot of experience here, why do you think that hasn't happened in our locales, in South America and in the USA, that things haven't been disseminated this way so that 70%, 80% of cases are still being done open?
Well, I think it has been disseminated that way. I mean, I think what's happened is a lot of people waited until there were easier ways to jump into laparoscopy and have embraced it to some degree. I'm not sure some of these data are coding it appropriately. For example, a hand port, because there's no code, may end up being coded as an open procedure. I don't know if they're coding as laparoscopic. But a lot more people who weren't getting involved have gotten involved with the hand port because it's easier. And also the robot, as was mentioned, it makes the procedure easier. And if you weren't doing it laparoscopic,
but still the data is only, I mean, the data is only at best 30% is being done in the States laparoscopically.
But it's still increasing. It may be a slower increase because it's a bigger country and there are more remote areas than there are in the UK. And, you know, when you start looking at, you know, that map of obesity, the map of the distribution of surgeons per capita is something very similar. And as you go away from the coasts and major urban areas, there are a lot of people who, as general surgeons, will not hit those numbers they need to be able to develop expertise. And there's not a choice unless every patient in the middle of some rural area is going to go 300 miles for their operation or 1,000 miles for their operation. And that is a different paradigm. And that exists in Argentina too. You know, when you have a large country with some population areas, great spaces between them, it may not happen the same as in the UK.
Okay, I said that was going to be the last two comments, but it's my prerogative to change my mind, and we'll take one last question from the floor.
Thank you. Mala Thanapan. I'm in private practice, general surgeon in Milwaukee, Wisconsin. It took me a long time to learn this. And you guys all, I think this is a very self-selected group. I hear over and over that we've disseminated this, but we have not. In Milwaukee, there are many, many community surgeons out there doing open surgery. How do we disseminate this to them?
Do you have an idea what might have helped you to learn it more quickly?
Motivation. I've been out for 13 years. I started doing laparoscopic surgery in my residency, so I was interested and motivated. I have 13 other surgeons in my hospital. I don't think any of them know what SAGES is.
Did you have access to any courses like SAGES, ASCRS, things like that? And if you did, were they helpful?
I went to multiple courses. It probably took me 5 or 6 years of going to courses, working with people, getting the hospital to buy equipment, very time-intensive, labor-intensive, and then I was finally able to do it. And now, what happens now, I have a complication. It's scrutinized. The chairman, the peer review committee, and I come to this course and say, how can I be scrutinized for doing this?
Well, you are exactly the kind of folk we want to know about, so I'd love for you to come up here and give me your email and address afterwards. We've hit 5:30. Everybody else has been wonderful for staying here until now. We have the Meet the Leadership reception for residents, fellows, and new members over in the Sarzo restaurant at the Marriott River Center. And following that, there are buses leaving all 3 hotels for tonight's sing-off, so please come and join us. Thank you. Thank you to the panel.